Good afternoon, welcome. I'm excited that you all are with us this afternoon. We are going to be talking about empowering strategies for long stay advocacy. We'll go through introductions here first and then a few housekeeping items, and then we will jump right in. So I'll introduce myself first. My name is Kylie. I am a physical therapist by background. I am a clinical practice specialist with Aegis Therapies, and I also serve as a master clinician in the areas of neurologic physical therapy, as well as orthotics and prosthetics.
And I'm Kimberly Collins. I'm an occupational therapist by background. I'm the East Coast Senior Director of Rehab for our outpatient division, and I'm a master clinician in seating and positioning.
Hello, everybody. My name is Terry Holt. I am a COTA. I'm a master clinician in documentation, and I've been with Aegis Therapies since 1992, and I'm currently a staff therapist in Georgia.
Good afternoon. I'm Lisa Messel. I am an occupational therapist. I'm a director of rehab in Southern Indiana, and I have my master clinician in service delivery.
All right, fantastic. I think what we will go ahead and do is move into some housekeeping. So just as a reminder, all of your lines are on mute. So if you have a question, go ahead and use the chat feature. In that chat, you will also see that Shyla has provided her email, which if you are a speech therapist and will be filling out your ASHA bubble sheet, you will be able to download that in the handouts and email it to Shyla. And please inform the moderator if you have anyone that you are potentially sharing a screen with. We want to ensure that you get credit for this course, and so therefore please put your email of that secondary participant in the chat feature. The course certificates will be sent out to your email automatically within 1 to 2 weeks of this course, and it will be approximately an hour long and will be available for questions following the presentation. All right, so we are just going to jump right into the objectives here. After this presentation, we want clinicians to be able to understand why a robust patient identification process is important and how this leads to a successful long-stay advocacy program. Clinicians will be able to identify 3 new practice strategies associated with patient identification, and clinicians will be able to identify 2 common pitfalls when completing screens. So why is long-stay advocacy important?
Hey, Kylie.
Yes, Shyla.
The PowerPoint is still on the empowering strategies for long stay, the main cover. I'm not sure.
Okay, let me pause my screen and re-share and see if that is the solution.
Okay.
All right, Shyla, how do we look now?
Looking good.
Great.
Thank
Sorry
you.
about that, everyone. So jumping back in here, We're going to discuss a little bit about assisted living facility and skilled nursing facility statistics and comorbidities. And this is important because of the residents that we serve. They are very complex and they have a lot of comorbidities. And so we have approximately 1.4 million adults living in skilled nursing facilities across the US, and more than 800,000 residents living in assisted living facilities. Some may have most or all of these comorbidities listed, such as arthritis, heart disease, diabetes, hypertension, depression, Alzheimer's, or dementia. And that creates a very complex patient, and we are the best people to help them work through some of these common comorbidities. Our goal is to provide excellent care for our residents. And in order to be successful with that initiative, we really need to have a partnership amongst the residents, the facility, and the therapy staff in order to work cohesively to a common goal. We as the therapists have the ability to provide meaningful and significant impact in the lives of our residents. We have the most tools in our toolbox to create needed change for our patients. That really should be an empowering and motivating statement. And this here on our screen is just one example of an opportunity that we can use to educate our customers and residents and their families and how we can positively impact their lives. It's important to have frequent open dialogue, as the typical view of our scope of practice is often narrow and not comprehensive to our discipline. So for example, if we just look at what can speech therapy do? Certainly this is just hitting one of our components, but if we really dive in, this can help be a great educational tool to be able to provide information on speech therapy's ability to increase alertness, to work on sequencing actions, improve activities to help problem solve, increase short-term and long-term memory. And then below that too, we can use this as an educational opportunity to point out potentially functional deficits which may trigger and indicate a speech language pathology screen, such as increased difficulty in the patient finding his or her room, declining ability to communicate daily wants and needs. Potentially it's a withdrawal from a social conversation or situation, or an increased need for repetition during conversation. This just highlights some really good questions and demonstrates the full breadth of the scope of the practice of a speech therapist, for example. We're going to jump into a polling question next. But I want you all to think about this question and respond. How familiar you are with OBRA and its impact on long-term care?
We'll give it a minute or so, and then I will close the poll, Kylie.
Sounds great. So if you haven't yet responded, thinking about very familiar, I completely understand OBRA, or I've heard the acronym, but I'm just really not sure the impact and how it affects my residents and my facility, or not familiar at all. All right, so I think we'll kind of wrap up here, and I can share that 15% answered very familiar, 47% answered I've heard the acronym but unsure of the impact, and 38% of you have answered not familiar. So thank you for answering that, and then we're going to kind of dive right in. So OBRA is an acronym for the Omnibus Budget Reconciliation Act. That's a mouthful. It doesn't really even sound like it even pertains to therapy when you first read it, but the primary purpose was to improve the quality of life and improve the quality of care of our long-term care residents. This was a federal law that was enacted by Congress back in 1987 that had a significant impact on long-term care facilities. It really set federal minimum care standards and created comprehensive individualized care plans, which were centered around preventing a decline in ADLs, pressure-related injuries, falls, worked on improving access to therapy services to meet the resident needs, and attempted to restore previous levels of function if declines were identified. So overall, OBRA really is a cornerstone of how the relationships further develop between therapy, residents, and our facilities in order to meet very specific individualized needs of our patients to ensure that we're helping them live their very best lives. We're going to go ahead and jump into and switch to SLP services. And I'm going to hand it over the microphone now.
So we're going to talk about PT, OT, and ST services. So as people age, everyday movements and tasks become more challenging and can even pose a threat to safety and independence. Therapy services can help to slow the disabling effect of progressive disease. As examples, but not all inclusive, PT can address strength training, fall prevention, pain management. OT can address strength training, training patients how to perform old tasks in new ways. And speech can address cognitive, speech, and safe swallowing. Let's look at the scope of practice grids to understand how this all works. So as we look at the PT scope of practice grid, we can use this to make sure we are checking or at least thinking clinically and critically about a patient. As you look at the grid, you will see functional deficits along the top, and down the vertical grid are the underlying impairments. These are the areas that are causing the deficits with the functional mobility. It is a way to look at a patient to identify deficit areas. You might also listen for some of the complaints of your patients when you are screening, when they say, "I get so short of breath," and identify that there are functional deficits impacted by that underlying impairment. If you familiarize yourself with the other disciplines, the scope of practice grid, you can quickly identify the need for therapy for another discipline, like occupational therapy. So the occupational therapy scope of practice grid has ADL and IADL functional deficits and the underlying impairments, impacting functional independence. Again, as a strategy, you can listen to CNAs and nursing describe what is going on with their residents, and you can quickly identify the underlying impairments and understand the impact that can have on functional abilities. And then there's the speech therapy scope of practice grid. Following the functional deficits and underlying impairments, you can identify a direct correlation of underlying impairment to function. So now we've talked about why we screen, who we screen, and what we are screening for. Now let's talk about how you screen and identify those patients. So we have a polling question. And it says, which one of these items is not a standard practice in the screening process? So we'll give you a minute to look at those. Okay, so let's talk about the polling questions because people have checked each one of them. So let's go through each one of them. So screening across all disciplines is appropriate, and you can use the scope of practice grids as a guideline. So looking at interviewing caregivers, absolutely. You want to talk with the caregivers. They know the residents the best and usually are the first to identify a change in function. Completing a chart review. Yes, you can complete a chart review looking at orders to see if there are new meds, new tests. You can look at the MDS to compare quarterly assessments, and you can even look in the progress notes for any changes. So 76% of you chose D, which is the correct answer. Transferring the patient out of bed is not a standard practice in the screening process. Let's see why. A screen has one purpose: to answer the question, is an evaluation needed? As soon as you can answer yes to that question, the screening process is over, and you should proceed with gaining approval to evaluate the resident. As you are gathering information to find the answer to whether an eval is needed or not, you need to keep an open mind. You should be asking yourself questions. Where can I help? What can I improve? What does the patient want to work on now? When you don't allow past performances or assumptions about a patient to interfere with a current screen, it will benefit the patient, allowing you to more objectively identify needs of the patient. Here are some common pitfalls that even the most experienced therapists fall into when performing screens. No change in function. Why? How do you know? When we screen, we need to be asking better questions. A quick, hey, is there anything different with Mrs. Smith, will not generate a conversation that may lead to appropriate identification of changes. Ask open-ended questions. Ask the caregiver or patient if they need more assistance for a task more recently. They refused therapy in the past. Each time you screen someone, you should approach it with fresh eyes and a clean slate. Just because they have refused in the past does not mean that they will refuse again. Everyone deserves a chance to benefit from therapy. If it is needed, stay positive. They will just decline again. I treated this resident 6 months ago and he was able to walk 50 feet at discharge. Now he can't walk at all. If I evaluate and treat him, he will just decline again. Does this sound familiar? Well, always keep in mind what is best for the resident, regardless of what has happened in the past. The resident's identified deficits during a screen are in the present time. I'm afraid I'll get a denial. If the care is needed and you provide strong documentation to support the need, you don't have to fear a denial. I see a need, but I just don't know what to do about it. Ask for help. Ask your colleagues, your directors of rehab, your clinical specialists, your master clinicians. We all want to do what is right for the residents and will provide you the support needed. They were just on caseload. Well, my question to you, were they really just on your caseload? It is easy to lose track of time, and when you feel that way, I challenge you to actually look at the last date you had the patient on caseload. You may be surprised. But there are occasions that, yes, the patient was just on caseload. Again, this goes back to the mindset you have during a screen. And if there's truly a change and a need, we need to evaluate the resident. Now that you have worked through the pitfalls and are moving forward with your screen, what next? There are 3 universal rules when screening. First, a screen is hands off. So that means that you can't walk the patient, you can't check the range of motion, or ask them to try a bite of consistency that isn't on their current diet. Secondly, you can't make recommendations based on what you observe, such as they need a new splint or a diet change, or they need a new piece of equipment. And lastly, it is appropriate to refer to another discipline for a screen if you observe a need. How do I gather information? There are a few different places and ways you can get the information you need to answer your question, is an evaluation needed? First, look in the chart under interdisciplinary progress notes, the MDS section, physician orders, risk committee meeting notes for weight loss, falls, or behaviors. These all provide information about what the resident is doing and whether any problems have been identified. Based on your setting, charts might not exist, such as in independent living, or be very minimal, such as in assisted living. So it can't be your only source of information. Next, talk with the caregivers. Both the community staff and family members can be a wealth of information. However, you must ask specific open-ended questions. Simply asking if the resident is okay or if there has been a change in function won't always give you the information that you need. Lastly, and probably most important, talk with the resident. You may observe things that aren't noted in the chart, such as positioning issues, cognitive impairments, or contractures developing. In addition, the resident may be able to communicate needs or desires to you that aren't in the chart. And let me give you an example. So there was a resident in an independent living community that wanted to work on shuffling cards, to play bridge, and to open her favorite snack. Without taking the time to talk with her, it never would have been known that she was having trouble with these tasks and that they were important to her. So what happens if you are still unsure whether an evaluation is needed after you have observed the resident, reviewed the chart, and talked with the caregivers and the resident? First, did completing the screen take more than 15 minutes? Second, do you feel compelled to do something hands-on with the resident? And finally, do you still have more questions? If the answer to any of these questions is yes, then proceed with gaining approval for the evaluation.
Okay, we are now on to a new polling question. If a resident flags for decreased participation in ADLs and activities, what disciplines are appropriate for referral? So take a few minutes to answer. Should it just be PT or just OT or speech? Should it all be all three? Should it just be PT and OT? You decide. Okay. So I think we can close the question. Okay. So if you answered all three disciplines, you are correct. If you just answered OT, PT, or speech, you're also correct. If the resident flags for decreased participation in ADLs and activities, the question is, which ADLs are they having difficulty with and which activities are they having difficulty with? If they're not able to get dressed because they are having problems with the movement of dressing, or they're having problems with organizing their thoughts and sequencing through the activity, then OT and speech are definitely indicated. If they're having trouble with their balance when they're standing to complete their self-care or to complete the activities they want to be involved in, then you might want to also pull in PT as well as OT. So if this is the case, really all three disciplines should be screening this patient to see if they need to get involved with the care. So what we're going to do now, we've talked a lot about the skills of the occupational therapist, the physical therapist, and the speech therapist. We've talked about what the benefits of therapy would be for our residents. We talked about why we need to screen, and we also talked about how to screen. So now we're going to go on to look at some tools that we can use for screening and also look at some opportunities to screen. So on right now is one resident screening form that you can use, and this involves all 3 therapies. This is a good form to use because it's very simple. It gives basic breakdowns, but it also gives you an opportunity to look at, can OT help here? Can PT help here? Can speech help here? This is a screen form that can be done by all 3 therapists individually. But also, if you have a therapist in your department that you feel is strong enough to do the screen on their own, they can take this form, go through the screening process, and mark off which therapies they think need to be involved. And then the team can sit down and look at this patient and make a decision whether they're going to follow through with treatment at that time. And on the next slide, we also have another multidisciplinary screen. And this screen, as well as the last screen, follows along the scope of practice grids. This one is basically the same, a little bit more involved, but it goes over the OT functional deficits, PT, and speech. And again, this is a screen form that can be done by each therapist individually. Or again, if you have one therapist that is strong enough to do the screen on their own, they can go through, complete the screen, and then bring it back to the team and decide how they're going to move forward. And if you look on the left-hand side, it talks a lot about, is there a change of condition in any of these areas? Is there a recent change in the patient's safety status? Is there a need to modify or create an F&P? You know, a lot of times I think we stop and think, well, they're in restorative, they have a functional maintenance program, they should be okay, I don't need to pick them up. Well, a lot of times we need to get back in there and look at that functional maintenance program and make sure, is it still appropriate for that patient? And if it's not, then we need to get back in there and see what we need to do to adjust that program. Does the patient demonstrate varying levels of performance during a 24-hour period? And this is where looking at the chart and looking at the nurse's notes is very helpful when you're screening a patient, because they may do well during the day, but in the evening or at night, it may be a totally different situation. A lot of our falls occur in the evening and at night because the resident is sleepy, they're not paying attention. And so we need to find out what are they doing over a 24-hour period, not just what they're doing during the day while the therapist is in the building. And does the potential exist for the patient to decline further without intervention? That's probably one of the most important ones that we need to look at. Is this patient going to continue to decline if we do not get involved? So we can go on to the next screen. These are some red flag indicators associated with changes in function. You know, we know that if we look at, if we're doing a screen, if they're had a decline in the use of their limbs or their ability to transfer, we know if they've had a decline in their self-care or decline in their available movement. We know those are things we need to see patients for, but sometimes we overlook a few things, like, is this patient requiring a restraint, or is nursing coming to you saying, you know, we need to come up with a way to keep this patient from standing up, or they're sliding out of their wheelchair, or they're having trouble using their walker and they want to put them in a wheelchair. We need to be looking at that. Are they having pain? Is it new pain, or is the pain that they have getting worse? Are there skin integrity issues going on that we need to look at? Is there weight loss and dehydration? We have someone that goes out to the hospital with dehydration and they come back. We need to look at that. Have they had a diet change? Has nursing downgraded someone and you found out through your screen that their diet was downgraded? We need to get in there and pick that patient up and find out why. Is there a decline in their ability to hold conversations or understand instructions? And that is one where talking with the caregivers can really be helpful, because we only see the patients for maybe an hour at a time, or we're only in the building for brief periods. Those caregivers are with them 24 hours a day. So they can give you more beneficial information as to if they're having more difficulty, the patient having more difficulty following their instructions when they're working with them. Are they having visual deficits? I think that's one that kind of gets ignored a lot of times, that there's visual changes going on. We need to find out what's causing those visual changes. Is there a decline in their ability to perform productive or leisure activities? If they're very involved in their facility with going to play bridge or going out on outings, and all of a sudden they're not wanting to go on the outing, or they're having trouble getting on and off the bus, things like that, then we need to look to see what can we do to help that resident get back to where they want to be. Are there changes in their respiratory rate? Is it decreasing? Is it increasing? Are they running a fever? All of a sudden, are they on oxygen, or have their oxygen liters increased from 2 liters to 3? Are they having a productive cough? Is there change in their sputum color? All those kind of things are triggers to let us know, red flag indicators that we need to see there's changes in the function going on with that patient, and we as therapists need to get in there and look at them and find out what's causing that change, and see how we can either adapt, restore, or compensate for those changes that are going on with that resident. Okay, moving on. This is just a real simple form that can be used. It's called Hey Rehab. It just kind of gives real basic information. This is a screen form that can be filled out by nursing, anyone within a facility, housekeeping, maintenance, family members. Anyone can fill out this form. It's just you go through, have they had a fall? Do they seem like they're having trouble getting dressed? Are they struggling with transferring? Are they having swallowing problems? Do you feel like their splint is not fitting right, or they've had a weight loss? This is a real quick form that can be filled out and put in the therapy box, and then you as a therapist can go back and maybe delve a little bit more into that patient, do a more thorough screen to find out what exactly is going on with that patient or that resident. Okay, so now we're going to talk a little bit about focus screens. These are screens that can be done at any time. They can be to help divide up, to go into your facility and just really hone in on very specific issues. Behaviors and mental health. You may decide this week we're really going to go through and look at everyone in our facility and see who's had changes in their behavior, or who's had changes in their cardiac condition, or who seems to be having contractures or seems to have more joint tightness going on, or decline in mobility. These are just very focused areas that you can look at and maybe divide them up over week to week to make sure we're not missing anything, and make sure we've covered, that we're looking specifically at each patient as to what might be going on. Okay. And then the next screen, we're going to talk a little bit about opportunities where you can go in and do screens, and do a quick screen and then follow up with a more involved screen. Going to fall meetings in your facility is a good way to do a quick screen or a quick identification of a patient that maybe you need to follow up on, do a more involved screen and see if we need to get involved. Attending wound meetings, restraint meetings, pain, weight loss, and restorative are all good ways to identify residents and patients with therapy needs. Encouraging your nursing staff to call when they see significant changes, and that's where that Hey Therapy form can come in. Or have an orientation system in place for new hires. Attend orientation or ask your facility, hey, can I be involved in the orientation process, so you can explain a little bit to the new nursing staff or CNAs how they can go about letting therapy know if they see changes in their resident. You can use your quality indicator report. In some facilities, it's called the Casper report. Is also a good way to identify specific changes in patients, because that's where some of those focus screens will come in, because it will identify specific areas of change that are going on with your resident. Have a regular screening schedule for your residents. You may assign someone to be in the dining room every day, or to go around and check on all the residents that are bedbound, or going in during activities to see who's struggling with being involved in the activity schedule for the day. just going around to the different lounges in the facility to see if you see changes in residents. Are people, do you have someone who seems to be sleeping a lot or is not interacting with other residents? Do you have people that aren't coming out of their rooms at all? Those are good opportunities to screen, to go in and find out, hey, what's going on here? Why are they being this way? Another good opportunity to have a regular screen schedule is to use your quarterly screens or your ARD screens from your MDS coordinator. Ask them to hand you, which ARDs or which quarterly reports are you doing, which MDSs are you doing for this quarter. Ask them to give you that, and you can go through and screen those patients and see if you see changes from their previous MDS. And have a system in place to review patients that have recently been discharged from therapy. And this is when, attending that restorative meeting may be very helpful to see what's going on with your residents. Are they starting to decline again? Maybe you need to get back in there and relook at that restorative program that you developed. So, and talking to restorative nursing to see if there's been any changes with that resident. And with that, we're going to move on to ALFs and ILFs.
Thank you. So identifying who to screen is a little different in assisted and independent living communities, since there are not quarterly and annual assessments, such as in the long-term care facilities. Also, we've been invited into their home, so we can't just go through and screen everybody and knock on everybody's doors like you can in skilled and long-term care facilities. But there are several different avenues that we can pursue to identify residents for therapy. A representative from therapy can perform a courtesy visit for all new residents that are moving in within the first week. You can accomplish a couple of things by doing this. First, you can greet them. Make sure they're aware that therapy is in the building. You can also have the opportunity to observe them in their new environment. See how they're moving around. Share a little bit about what the different therapies do and what they can provide to them, because the point is to keep them strong, healthy, on their feet, and living where they want to. We can also touch base with anybody who's returned from the hospital or who has had an emergency department visit within a day or two of them coming back to see if there's been a change in status or new orders for therapy were provided. This information can be a little harder to obtain in independent living communities because there's usually not a wellness director or nurse in the building. However, developing strong relationships with the community staff, front desk, concierge, and the residents, you'll be able to stay connected to what's happening even behind closed doors. We also want to encourage staff and families to communicate any potential therapy needs and changes that they notice. Go to thank you. Lastly, a therapy representative should also participate in community collaborative care meetings. If they have them, a lot of independent living communities won't. This meeting can have many different names, but it's an interdisciplinary team meeting with the focus of discussing a few of the following items: new residents, when they're coming, hospitalizations and residents that are returning from rehab, and who's following up with them, any incidences or changes of condition, residents who are at medium or high risk of moving out, new residents of concern for when there's just something that doesn't quite feel right, and then follow up on any action plans that have happened since the last meeting. So this is an example of a courtesy visit request form. It's an example of one of the ways that we can encourage staff to communicate and share if they've noticed any changes with their residents. It can also double as a screen form for multiple disciplines, and we can start gathering that information that we would need for an intake process in outpatient. So we have a quick polling question: true or false? The clinician completing the courtesy visit is an OT, and they have identified a resident with unexplained weight loss. Can they recommend speech? Give you guys just a few more seconds there to answer. All right, and 95% of you guys picked true, which is correct, since the purpose of a courtesy visit or screen is just to answer the question, is more information needed? One discipline can definitely recommend another discipline. Come take a look. So in outpatient, we also have a similar HAY therapy forum to what we have in our skilled nursing side. In this one, we have done a little bit more layman's terms, since family members, residents will tell on each other. So we wanted to really be simple for them. So things like, this person doesn't speak clearly or they're mumbling. This person's having issues getting up from a chair. Really simple things like that that they can indicate. And we can go take a look. So that brings us to the end of our presentation. So do we want to go through questions? Did any come in? All right. So, guys have any questions? Please feel free to answer those while feel free to ask those while you guys are doing that. Remember, your certificates will be emailed to you. We have these impact webinars monthly, so please join us in the future. And remember, if you are a speech therapist, to fill out that ASHA form that is in the handouts and email it to Shyla. And her email address is in the chat.
Hey, Kimberly, we have a question. Where do you get the HAY therapy forms?
So if you're an Aegis therapist, ask your director of rehab. They can order them for the facility.
Okay.
Do we have any others?
That's it for now. I'll give a few more questions. I'll give it a few more seconds.
Yeah.
Are any of the forms mentioned available online?
So within the Aegis, yes, they're in various SharePoints or in the clinical field resources in Teams. Kylie, all the therapists have access to that, correct?
You are correct. Yes, I was just going to jump in. So if you are an Aegis employee, we have a robust amount of the resources in the clinical field resources. Though if you're looking for a particular unique form, certainly reach out to your DOR or your CPS and we'd be happy to provide them. But most of the forms we have used are not public facing today.
And I've seen a couple of questions about the ASHA CEUs and the bubble sheet, where to send it to. You're not seeing my email address in the chat, so I will just say it's Shyla, SHYLA .Hamrick, HAMRICK @aegistherapies.com. Is there a source for the Hey Therapies forums online that you would recommend?
It's really a form that you could create on your own, I think. You know, if you sit down and think through just the basics, what we talked about, you could actually, you know, create your own form for your facility.
Okay. Again, the email address is Shyla, SHYLA .Hamrick, HAMRICK at aegistherapies.com. Any suggestions on who to contact for help at home after rehab if no one to go home to?
That depends a lot on community. If they are in their personal home, obviously home health therapy, there's lots of different companies depending on what area you're in. But then also there's, you know, private personal care for that non-skilled assistance. And then a lot of, if they're in an assisted living community, a lot of them have resident care aides or can bring home health in if there is not a therapy provider on site.
All right. It doesn't look like there's any more questions. One more time, my email is Shyla, SHYLA .Hamrick, HAMRICK at aegistherapies.com. All right, and I believe that is the end of our questions.
All right. Well, thank you everybody for joining. We greatly appreciate it and hope you found it helpful.
Awesome. And with that, we will conclude. Thanks, guys.
Thank you, everyone.